I'm a basic scientist. Today I want to tell you a story about the translational research, the interaction between basic scientists and clinician that allows new advances in basic science concepts and clinical treatment of patients. So the talk today is in vitro activation of ovarian follicles from bench to the clinic. In this slide, you can see that the ovarian follicle come from the left-hand bottom corner. Those are the primordial follicles. The primordial follicles start to grow and become primary, secondary, and eventually reach the early entrant follicle. Most of the follicle at the early entrant stage actually undergo atresia or apoptosis. Then the FSH treatment in patients or the regular circulating FSH will allow some of the follicle to survive and continue to grow, and eventually in human we have one preovulatory follicle per cycle. And you can see the dashed line indicates the most clinical treatment dealing with the FSH treatment from the early entrant follicle to the large follicle and allow ovulation. However, today's talk, we're actually going to emphasize all the follicle below the dashed line. And in the below the dashed line, you can see the primordial follicle. Actually, in the human ovary, we have 800,000 of these primordial follicles, and most of them remain dormant. So there are dormancy factors controlling their dormancy. However, earlier studies have shown that stimulation of the AKT pathway can allow some of the follicle to grow. So we call this as initial recruitment. And for all the talk, all the slides I'm going to show today, you can find them in a review article on the right-hand corner, intra-ovarian control of early follicular genesis. In this slide, it shows the basic signaling molecule, signaling pathway in the oocyte that's control the dormancy. We basically have two breaks in the oocyte of primordial follicle to make sure that the follicle will not grow. Because if follicle all start to grow at inappropriate early time, we will end up have premature ovarian failure. So one of the break is a transcriptional factor called FOXO3 in the right-hand corner. And once the FOXO3 is taken out, then all the follicle will start to grow. All the primordial follicle will start to grow. In the same time, there is another break that you can see on the top here. Some growth factor will stimulate the receptor tyrosine kinase, RTK, which then increase the activity of the PI3 kinase, and PI3 kinase converts PIP2 to PIP3. However, inside the oocyte, there is always this enzyme called P10, PTEN on top. If you take away that enzyme, then it will increase the PIP3 levels and increase the AKT levels. So people have done is to perform oocyte-specific deletion of the P10 gene, and as shown in the in this slide now, it's published in 2008. This Reddy et al. Published in Science. Next slide shows that in this paper, they demonstrate that if they take away the P10 gene, which you can see the left-hand three pictures are the wild type, and the right-hand side are the P10 knockout animal ovary, and the further right-hand are the higher magnification. One thing very interesting is if you look at D compared to E. In the E group picture, deletion of the P10 gene led to a major growth of the follicles. Therefore, you can see even the ovary look bigger. However, and that's at postnatal day 35. However, by postnatal day 16 weeks between G and H. You can see in the H group, the P10 knockout group, all the follicle are gone. So ovary actually have nothing, no follicle left. So because P10 is an enzyme, we follow this original finding and ask the question, is it possible, as shown in this slide on the top middle, is it possible to use P10 inhibitors to perform something similar to the P10 knockout? Because if we want to use this as a method to activate the dormant follicles in the patient, we have to use some drugs, and then this treatment has to be a short-term treatment. So we made a hypothesis that we can use P10 inhibitor to inhibit this enzyme activity and to promote the follicle to grow. And in the same pathway, you can see on the left-hand corner, RTK receptor is activated by growth factor, which will do the same thing, that will increase PI3K and then eventually increase AKT. That should also increase the promote the follicle growth. So we use a 740YP, which is an AKT stimulator. It's a peptide that synthetic peptide that mimic the PDGF receptor intracellular region, 9 amino acid peptide, but we made this peptide as a phospholipeptide because once the receptor activated by the ligand, the PDGF in this case, the intracellular region will be phosphorylated. Then we fuse this 9 amino acid to a fly protein to allow it to go inside the cell. So we are using a 25 amino acid peptide that will do the same thing as you activate the receptor. So in this slide, we published in 2010, using a model of rodent model, we took day 3 animal, as shown in left-hand upper corner, number 1 there. Day 3 animals, the ovary only have primordial follicles. So we took the 1 ovary out and treated with P10 inhibitor. The other side of the ovary, we took it out and without any treatment. The concept of this experiment is you only need short-term treatment to activate the follicles. Once they are activated, then what we did was we took, after taking out in vitro, then we put it back into the best place for it to grow. In this case, we put under the kidney capsule of the host. And we allow 2 weeks to grow because we know during the 2 weeks, the primordial follicle will reach the pre-ovulatory stage. So we call this procedure as in vitro activation. And as you can see in the next slide, that is in the kidney graft, on the left-hand side, each are matching ones. That is, one is controlled, the other is treated. And on the right-hand side, we showed that when we took out 5 different pairs of the ovary, all the ones treated with P10 inhibitor are much bigger than the control one. And in the middle panel, right-hand side, also, you can see with the 740YP, this PI3K activator, it will give us the same result. And then the bottom right-hand, you can see that when both the P10 inhibitor and the AKT PI3K activator are added together, you see even bigger in terms of the ovarian weight, suggesting the follicle growth. And we can actually obtain the oocyte from these follicles, and the top panel shows that we can actually fertilize this oocyte and we can get embryo development, and right-hand corner show we can even have healthy progeny after the embryo transfer. So this demonstrated using the rodent model, the whole process can be performed by using the drugs to activate the dormant follicles, primordial follicles. So then we push this to the clinical human situation. As you can see in this slide, we use the cortex region, which only contain, the human cortex only contain primordial follicles. We cut out the small fragment from patients who donate a very small piece of their ovarian cortex. On the left-hand side, it shows one group is treated with P10 inhibitor, the other is not treated. Then we transplant this activated, in vitro activated ovarian fragments into the new mice, immune deficient mice, into the kidney capsule. And in the human, from the primordial follicle growing into the preovulative follicle will take 4 to 6 months. In this case, 6 months later, the animal were injected with one injection of ACG to induce oocyte maturation, and then the ovary were taken out. As you can see on the right-hand side, upper corner, we were very surprised by the result and very happy to see the result. That is, the control group, the top one, are very small ovary fragments, and the lower one, the one treated with the P10 inhibitor, BPV-PIG. And you can see that the ovary graft is almost as big as the kidney themselves. So this really shows the whole process. The human primordial follicle can be activated. And because we have injected these animals, the host, with ACG, we can actually section the ovary, and we can see mature oocyte can be obtained. So in this case, it allows us to go to the next step, trying to use this for the treatment of patients. As you can see in this slide, the primary ovarian insufficiency, also known as premature ovarian failure, is a condition characterized by amenorrhea that's of patient less than 40 years of age. So this disease condition only affects 1% of women, but this is an extreme condition. That is, this patient usually gonadotropin treatment is not effective, and then they cannot have their own children. So the only way is to have oocyte donation from somebody else. So in this type of patient, we collaborate with Dr. Kawamura in Japan, and then we collaborate with him. He start to use the drugs we have, in vitro activation IVA drugs, and then he, as shown in the right-hand side, he took out one ovary and then cryopreserved some of the ovarian pieces. And then when the patient's ready, he took out some of the pieces, only about 1/4 is needed from the ovary is needed, and took out one of the pieces, and then he cut them into small pieces, fragment them. Fragmentation. The reason is these pieces eventually have to put back into the patient through the auto-transplantation approach. He made a pouch under the fallopian tube. Okay, and certainly during the 2-day outside, the in vitro activation drug were included for the treatment. So this is the idea. That is, if we can have patients who have who have reached menopause very early in life, but they still have primordial follicles, maybe we can activate those follicles, and then we can monitor the follicle growth and eventually get the oocyte. As you can see on the left-hand lower corner, there were 3 patients at that time, and the arrow indicates preovulatory follicles start to grow, and the double dots, the dots on top shows follicles, preovulatory follicle, and then in some of them, the arrow shows further there's actually oocyte have been retrieved. So the result come out very surprising and very nice. That is, we can have all 3 patients, the original 3 patients have very nice follicle growth at different time. And the doctor was very happy, the patient was the patients were very happy. However, we as basic scientists was really surprised by the finding and somehow depressed, because you can see that actually in patient number 1 and 3, the preovulatory follicle was obtained within 3 weeks. after degrafting, suggesting our original hypothesis that it took 4 to 6 months for the primordial follicle to go all the way to the preovulatory follicle. Something is wrong. It does not fit our original hypothesis. So we begin to try to figure out what is going on. And one of the process of this whole procedure is, as I mentioned earlier, the right-hand corner, the fragmentation step. Okay, the tissue has to be put into small pieces in order to allow better vasculature inside the body of the patient. So we went back to the literature, and as you know, the other disease that's really much higher incidence in patient is 5 to 10% of women at reproductive age have polycystic ovary syndrome. Very interestingly, even as early as 1935, Stanford, when they first reported the case, they always make the wedge resection, cut out a small piece of the ovary, and then trying to look at histologically what happened. And in all 7 cases, the original reported of this amenorrhea patient, they found that all patients will start cycling. And later on, surgical ovarian wedge resection was largely abandoned due to post-surgical adhesion and medical ovulation induction using clomiphene and gonadotropins. However, as you can see on the lower right-hand corner, people are still using laparoscopic ovarian drilling. Basically, you burn holes in the ovary, and all the follicle will start to grow. So this data, this classical result, gave us some hints. Something is going on maybe in our human trial. So we asked the question, how could activated dormant primordial follicle grow into preovulatory follicle in this patient in just a few weeks? Are we unleashing the growth potential of arrested secondary follicle? Maybe it's really not the primordial follicle that grow all the way. Maybe we're allowing some secondary follicle to grow. So what is the cause of this growth? Maybe it's because our ovarian fragmentation of this POI patient's ovary. So then we also ask the same question, does ovarian wedge resection and laser drilling also unleash the growth of arrested early interim follicles? So we set up a new experiment, and as you can see on the left-hand side, so the mice now, we took out the mouse ovary, and this is now from day 10 animal now. So from day 10 animal, because they have secondary follicle and smaller follicle, so the largest follicle is secondary follicle. So we want to ask the question, can we cut the ovary and promote the secondary follicle to grow? So, so one side is cut it, the right-hand side cut it, and the other side is not, it remain intact, and then we transplanted this into the animal, the host. And because it's secondary follicle already on day 10, in day 10 ovary, so we only allow 5 days, which should allow it to grow to preovulatory follicle. And most importantly, this whole procedure has no IVA drug use now. So we are not using any chemical, just the cutting. And the biggest surprise came in this next slide. That is, the top one shows the pair ones, 3 pieces versus 1 intact one of the 3 pairs. And then when we took out the ovary, you can see that all the ones that with the damage, with cut into 3 fragmented ovaries, will all grow bigger. So this data shows to us that ovarian damage actually is causing the follicle to grow, and that was a surprise finding. And then we have to really repeat this many times by our group and then by our collaborator in Japan. Repeat all this data, and this is the final data you can see in this slide. In day 10, day 15 on the left-hand side are the ovary just taken out without any treatment, and they are growing from day 10 to day 15. And then because our hosts were injected with FSH, so we give FSH, and it doesn't do much. And the right-hand side, all these ones are incubation, our original incubation was for 48 hours because that's the IVA drug treatment. And we found out that if we do 3 pieces, go for 24 hours, 2 hours, or 1 hour, it all do the same thing. That is, it doesn't matter how long you put it outside, as long as you cut. And then we also found you cut into 2 pieces or 4 pieces, doesn't matter. Everything, all the black ones, black bars are the ones that cut. So no matter how many pieces you cut, no matter how long you incubate, it gives you the same result. So you only need very short-term incubation, and you can cut into different pieces, and it's the damage that's doing the job. So when we took out the ovary, you can see in this slide the pair one, the intact, versus the 3 small pieces one. And the interesting thing is when you check the follicle counting. So we did the follicle counting. If you concentrate on the right-hand figure, that is all the black one are the cut one. And you can see the right-hand side, the lower right-hand side antrum follicle and pre-ovulatory follicle, it's almost double. And the late secondary follicle also almost double. And but in the small follicles and the left-hand side, those primordial, primary, and secondary follicles, early secondary follicles, there's not much change. And you can see those follicles still is composed of the majority of the follicle. So it doesn't not really matter. The final ovary weight is really determined by the big follicles. Okay, so we can see big follicles are really growing after fragmentation. So then the biggest question facing us is, what is the mechanism? And this took us almost 6 months trying to figure out what's going on. One day I was reading the literature and showing that there is a system in the fly. You can see the picture. Fly and human actually has common ancestors 700 million years ago. But at that time, there's already a signaling system that's called hippo signaling system that's controlling the size of the organ. Okay, so 75 years ago, we know about the PCO and wedge resection, and our recent data shows the ovarian fragmentation, but the final story is actually due to the common mechanism between the human and fly. So in this slide, it shows that on top, it shows hippo tumor suppressor pathway. So this is a pathway to make sure the tissue will not become tumor. And it regulates organ size in Drosophila. And the same system is also found in the mammalian system. So this regulation of the system causes cancer in both systems. And in the A and B in the middle, you can see that in the fly, they have single cell mutation. And every single cell become a clump of tumor. And in the rodent model, you can see that C and D, if you delete some of the gene in this pathway, in this case MST1 and 2, in a liver-specific manner, then the liver becomes 5 times the size. And the lower right-hand corner, you can also see that even the heart is also controlled by this pathway. This is a deletion of SAR1 gene. In the tissue-specific, heart-specific manner, the heart also become major, big increase in size. If you look at the left-hand side diagram, so those are the genes, MST, LETs, and the most important one is a gene called YAP, Y-A-P, and this gene controls it will interact with nuclear transcription factor, TEAD, and then control the growth factors. So in general cases, in a normal tissue, YAP always stay in the cytoplasm and get degraded. So it cannot go into the nuclei. So in this case, because the serine kinase, MST, and all the serine kinase will phosphorate the YAP. But you can see we found that in the ovary, and day 10 ovary in this slide, every gene in this pathway is already in the ovary. We can see them based on the RT-PCR analysis. And theoretically, our cutting probably is disrupting this pathway so that it cannot phosphorylate YAP. So YAP will be under-phosphorylated. As you can see in the left-hand side, the phospho YAP is actually decreased after cutting into pieces. And if this is YAP is under-phosphorylated, it will go to the nuclei and it will stimulate downstream CCN growth factor based on the fly data. The data really shows clearly the YAP is going to the nucleus is based on this slide. That is 4 hours after the treatment, we can see that the same antibody staining with and without fragmentation give us very dark, strong signal because the nucleus is a smaller area, and then all the color begin to show much stronger. So we look at the CCN growth factor downstream of the YAP, the hypocycline, and in human they are, or mouse, there are 6 of them in comparison to 1 in the fly. So we check all 6 of them. 4 of them will show increase in their transcript levels, as you can see in the dashed line. The 2 type of dashed line, one is with transplantation, one is cutting without the transplantation. So this data then suggests all 4 growth factors are probably follicle stimulating factors, and we check them using the ovarian explant culture method. During a 4-day culture, you can see the left-hand side control is small in terms of ovarian weight. FSA treatment, as expected, increased a lot, and then increase in doses of all 4 CCN growth factor will stimulate the follicle increase in ovarian weight, and follicle counting shows on top increase the late secondary follicle from the primary stage. So when we count the follicle, we see that all 4 CCN growth factors can promote the follicle growth. And based on the fly, there is another group of genes called apoptosis inhibitors, and they are called BIRC apoptosis inhibitors. There are 7 of them, and we found that 2 of them will increase after cutting. Yeah. So in the human situation, we found similar story. That is, as you remember, we have frozen the ovary in cortical fragments in the patient, and then we cut them into small pieces before grafting. So we had done the similar experiment and followed by RT-PCR analysis of the all 4 factors. And you can see the open bars are the ones with further cutting, and the black ones are the ones without cutting. So all 4 growth factors will go up in the human system. So this data then raised the other issue, that is, what is causing the hypocycline disruption? Is it after the fragmentation? So we checked the literature, and the literature in the fly, they have taken away, perform the genome-wide RNA screening. They knocked down all 10,000 genes one at a time. They found all the genes upstream of the hypocycline to allow the YAP go to the nucleus are the genes involving actin polymerization. So the G-actin become F-actin. So then we ask the question, is the cutting, the ovarian fragmentation can promote the actin polymerization? And we can see, we measure the F-actin, F and G-actin levels, and you can see the black line shows the fragmented ovary, and the white line shows the without fragmentation. There is a transient increase in F-actin formation. So with this knowledge, knowing the mechanism, we can actually go to the next phase. That is, we can actually use intact ovary without any fragmentation. Now we can use this compound called JASP, which is an actin polymerization enhancing drug. We now take the intact ovary and then treat it with incubate with this drug. we can see on the left-hand side the F-actin increases. And then after this treatment for 30 minutes, we can then graft the whole ovary into the same model as we we have done earlier, and then we can get increase in follicle ovarian weight and then follicle growth. So furthermore, we use S1P, sphingosine 1-phosphate, which is a phospholipid that's already found in the follicular fluid, but it's usually bound by high-density lipoprotein. So this compound has been shown to increase actin polymerization. As you can see on the left-hand side, yes, indeed, we can take the ovary, we can see that, rodent ovary, you can see that. And if we treat the ovary outside the body for 2 days with this drug, this is the intact ovary, and after the drug treatment and then followed by grafting, we have our recent data shows that all the black ones are the ones with different doses of sphingosine S1P treatment. So this is the summary now. We can show that we can ovarian fragmentation increase F-actin formation, disrupt the hyposignaling, allow the YAP go to the nuclei, and stimulate downstream growth factor and apoptosis inhibitor, leading to follicle growth. Later on, we we went back to the clinical condition. We asked the question using the rodent model to show whether secondary follicle also respond to AKT stimulation. And this data says that shows that we can isolate out the secondary follicle from the rodent, and then we can use PTEN inhibitor and PI3 kinase enhancers together, and we call the AKT stimulators. We can actually see increase in follicle secondary follicle growth. And using the rodent model again, you can see the original data was using intact versus 3 pieces, the open bars that cause increase in follicle growth. And then the intact one, we add the IVA drugs, and it will grow even more. And then the 3 pieces, we add IVA drugs, it will also grow further. So this really proves that the clinical condition is due to the activation of the follicle growth by the drugs as well as by the hyposignaling disruption. So it's summarized here on top, showing the primordial follicle goes through this IVA drug treatment, and the secondary follicle goes through disruption of hyposignaling as well as AKT stimulation, leading to the pre-ovulatory follicles. So then, finally, we summarize all the data in the clinical setting. This is done together with the San Mariano team headed by Dr. Kawamura and Ishizuka. And on the left-hand corner, you can see 27 patients. They are only 37 years of age, and they already have 7 years of no menstrual cycle, already reached menopause. And these ovaries were taken, one ovary was taken out from each patient, and then they were cryopreserved and go through the same procedure as I already showed you. Then the mature oocyte were obtained, and then finally they can be transferred back to the patient. Embryo can be transferred back to the patient. This slide shows the important steps of autografting. That is, after cutting and drug treatment, they were put back into a pouch that made in the oviduct by Dr. Kawamura. And this summarized a group of 8 patients, and you can see a lot of follicle growth in this patient. And this is the first IVA baby, a picture of the first IVA baby, and the second baby was also born last year. So this whole approach not only allowed the treatment of infertile patients, also allow us to understand the mechanism. And interesting enough, this is the same slide I showed you earlier, but all the ones that underline shows that actually genome-wide analysis of different patients, such as POI patient or ovarian reserve, that is a patient who reach a little bit earlier into their menopause time, and patient with PCO. All these patients, the genome-wide analysis come out with the genes such as DIA, 2 and 3 are involving actin polymerization. For YAP, has been shown to be involved in PCO patient. And BIRC, the lower right-hand corner, shows apoptosis inhibitor. BIRC1 actually was found in the POI patient genome copy number changes in this gene. So I think to summarize, we show that the dormant follicle, primordial follicle can be activated. And then number 2, ovarian fragmentation can increase the actin polymerization and then lead to follicle growth. The red color shows one important information, that is biomechanical information, such as the rigidity of the ovarian capsules and intercellular tension can regulate the biochemical signaling. And number 3, the CCN growth factor, a follicle stimulating factor. And number 4, a lot of the non-dormant secondary follicle are also constrained to grow by local hyposignaling. This is actually changing our concept. We tried so many years trying to know the exact lifespan of follicles, but actually it's not fixed. So number 5 suggests that monthly damage to the surface epithelium could also disrupt hyposignaling and increase the susceptibility to ovarian cancer. So I think for this slide, I want to emphasize now, under the dashed line, there are a lot of follicles still can be activated to grow. That is, if you look at the right-hand side, we show that primary ovarian insufficient patient and early menopause patient can be, they have small follicle, can be activated to grow. And this approach, the IVA approach, may be useful for middle-aged infertile women who have irregular cycle and have a lot of infertility issues. And using this approach, we may be able to really help them. And as shown in the bottom, the age-dependent decline in follicle number and egg quality. So is always the age age is always associated with lower egg quality. The present IVA approach cannot solve the problem of egg quality, but can increase the number of follicles and mature oocytes. So now I want to thank our lab members on the left-hand side that participate in the work, and the right-hand side are the clinical team in Japan headed by Dr. Kawamura and Ishizuka that performed the study. Thank you.